So part two of MRI, just looking at some of the case studies demonstrated on here. So here looking at the knee itself, so visualised really nicely here, you can see the ACL, you can also see the PCL, so ACL here, PCL demonstrated posteriorly, and you can also see some evidence of the meniscus, both medial and lateral. So with a patient reporting restricted range of movement, there's some hemarthrosis and they're hearing snapping and popping within their knee itself, you can see here you've got this cloud-like ACL structure, so there's a rupture there, and then you're looking at the posterior horn of the meniscus. You can see this lucency here, so you've also got a posterior horn lateral meniscal tear, so ACL rupture and posterior horn lateral meniscal tear. Looking here, you can see the PCL quite nicely here. Recent history of trauma and also pain within the knee. You can see there's this increase in white around the PCL and actually within the PCL itself. So you've actually got a PCL edema here. The PCL doesn't seem to be ruptured or torn. There doesn't seem to be any disruption in the length of the edema in the PCL, sorry, but you have this associated edema. Looking at this knee here, so you can see they've had a recent injury, there's an audible clunk, they're in extreme pain, and then they've got a locked knee, so we know that that would indicate that there is in fact a meniscal injury. Looking at the for the bow tie sign, so you're looking at the meniscus here, but you can see this white line that goes all the way through the meniscus, and that indicates a bucket handle tear just there. And then looking at the PCL here, so in previously you could map the length of the PCL, but when we're looking here, that the PCL here, you can't see as well the insertion here, so it seems to be white. That would indicate that there is a PCL rupture or at least a tear here. Pain and lock-in, thinking about the meniscus, obviously. So you can see you've got the posterior aspect of the meniscus here and the anterior aspect here. You've got this white aspect, which is a meniscal cyst, sitting within the meniscus, which will disrupt the flow and the use of the meniscus. Then you've got this white lucency here, and also this dark here, which would indicate that there has been some bony bruising that has occurred during the trauma. Looking at this one, so we've got a history of twisting injury, medial joint pain and tenderness. So go with this one, think medial and lateral aspect. What can you see within this knee? Have a go at identifying the medial and lateral aspect of the knee itself. And what do you think is going on pathologically here? What do you think the pathology is within the knee itself based on what you can see? The answer is in the notes underneath if you wanted to have a look. So here looking at the patella, so we're looking at a skyline view of the patella itself, so you can see the patella sits here and it's sat within the trochlear groove, and we're looking at grade 1 to grade 4 chondromalacia patella. So just here you can see that response with the white irritation, and also here you can see this fuzziness on the posterior aspect of the patella. So looking here, again, you're looking at the meniscus, so looking for that nice bow tie sign, so that's demonstrated quite nicely here. So you've got that bow tie sign, but in the middle here, you've got this issue with the meniscus on the posterior aspect, and then looking here, you can also see that there's a disruption within the meniscus itself, indicative of potentially a meniscal tear. And looking at this, you've got a T1 and a T2 stir. And you can see in the posterior aspect of the knee, you've got this mass that's been found here, and this is an example of PVNS, so pigmented villonodular synovitis, and that's part of the thickening of the synovium itself. This is a giant cell tumour and is a benign tumour. You can see it on all three, just here. Moving down to the foot and the talar dome. So patient twisted injury 1 year ago, ongoing pain and not improving with physio treatment. So looking here, so you can see the talar dome itself, but you can see this abnormality that is sat just here. So you've got the osteochondral defect of the talar dome and a detached portion of the talar dome just there. So looking at this one here, you can see the increase in white response down here. So you can see that you've got a calcaneal spur. So if you follow the line of the calcaneus, you've got this jutting out spur down here, and also the swelling and the inflammation of the plantar fascia, showing plantar fasciitis and this calcaneal spur. And then looking at it here, you can see the thickening and the irritation. So the swelling here is shown in dark, depending on which sequence you're looking at. So looking here, this is a really nice example of a patient that presented with long-term pain and swelling, showing effusion and potentially an inflammatory arthropathy here. So you can see this fuzziness around the joint itself and like a cloud-like effect. Again, that would indicate some degree of inflammatory arthropathy. Looking at this hip here, so you can see this abnormal white mass here, and this would indicate bursitis, so inflammation of the bursa on the outside of the hip, normally diagnosed as Grace trochanteric pain syndrome. But you can see how inflamed and sore that would be for the patient. Here, looking at the hips and looking at the labrum of the hip itself, and you can see here you've got a labral tear just there, just where it nips up, and also you've got a labral tear just there. So instead of having a nice smooth surface, you've then got this nick in the surface of the labrum. Taking a look at the shoulder, so you can see you've got the Hill-Sachs lesion just there, so that nodule within the shoulder, so it's not nice and round. So every time that dislocates, it causes that Hill-Sachs defect, which will get bigger every time they dislocate. And again, you've got this Hill-Sachs lesion here, acts as like a cam. So every time they try and move, it can get stuck, and you get that anterior labral tear as well. So looking at the labrum itself, you're following around and looking at this lesion just here. So you're looking for lack of fluidity of the labrum, and that would be your tear just there. And then looking at impingement syndrome, which can ultimately lead to supraspinatus tears. So looking at the supraspinatus itself as it comes up and over the humeral head, you can see the irritation and the subclavian bursa underneath here, where it gets irritated as the supraspinatus comes up and round. And as you can see here, the supraspinatus is running along here and then is getting irritated, so it dips down underneath here. So you can see how that is going to cause an irritation as it moves up and over and causes pain with movement. Okay, so based on that, what I would like you to do is refer back to your case study for your summative assignment, and have a think about what imaging techniques were chosen for your case study, if there were any at all. Or looking back on what you know now, would you then refer that patient for an MRI scan?